Hi guys, now we are going to start arterial disorders part 2. In this chapter, we are going to discuss Raynaud's phenomena, acute mesenteric ischemia, mesenteric venous thrombosis, chronic mesenteric ischemia, subclavian artery stenosis, subclavian steal syndrome, aneurysm, aortic dissection, traumatic aortic rupture, vascular graft, and at the end, we will be discussing CABG, that is coronary artery bypass grafting. So let's start. Raynaud's phenomena. What happens in Raynaud's phenomena? There is episodic digital ischemia. Why? On exposure to cold, during emotional stress, or if the patient is using some vibrating tools. So there is episodic digital ischemia on exposure to cold in cases of emotional stress or if the patient is using vibrating tools. So in this case, what happens? Initially, you are going to notice that there is digital blanching, followed by there is cyanosis, followed by redness. So there is blanching, cyanosis, redness. How to remember? Mnemonic is Boy's Common Room, BCR. So you can see there is digital blanching. So there is blanching followed by cyanosis followed by redness. So redness of fingers and toes, this is BCR, right? What happens? How to remember? We discussed that Boy's Common Room. So see the sequence of events. There is blanching. Why blanching occurs? Because whenever there is exposure to cold, there will be spasm of these digital arterioles. And if there is spasm of digital arterioles, you can see here, what? There is blanching. So blanching, actually it is the stage of local syncope. After that, what will happen? After that, there is cyanosis. This is the stage of local asphyxia. Why? In this case, the capillaries and venules are going to dilate. And if capillaries and venules are going to dilate, what will happen? There is collection of deoxygenated blood. And because of collection of deoxygenated blood, what will happen? There is cyanosis. So why there is cyanosis? There is stage of local asphyxia. Here, there is collection of deoxygenated blood in capillaries and venules. And after that, there is redness. Why? Because there is recovery. So whenever there is recovery, there is resolution of digital spasm, and in that case, there is increased blood flow in the dilated arteries and capillaries. And whenever there is increased blood flow, you can see there is redness. So there is blanching, cyanosis, redness. Redness is the stage of recovery. So how to remember the sequence of events? Boy's Common Room in Raynaud's phenomena. Now see, Raynaud's phenomena, it is more common in fingers or toes. Yes, we saw here in the image. Obviously, it is more common in fingers. It is more common in fingers followed by toes. More common in fingers followed by toes. Here, mainly arterioles are involved. Major vessels are not involved. Mainly the smaller vessels, especially arterioles, are involved. So if you are going to check radial pulses, ulnar pulses or pedal pulses, pulses are normal. So radial, ulnar, pedal pulses, these are normal. You know what are the types? It is of two types, primary and secondary. Primary Raynaud's phenomena is also known as idiopathic. It is also known as Raynaud's disease, right? How to manage? See, more than 90% patients are going to improve after avoiding the stimulus. So we ask the patient to avoid cold stimulus. During winters, we ask the patient to wear warm gloves and avoid using vibrating tools. So what? More than 90% patients are going to improve after avoiding the stimulus. So avoid cold stimulus, wear warm gloves during winters, and avoid the use of vibrating tools. Still, if patient is not improving, imagine, still there is no improvement. Still there is no improvement. Even after avoidance of stimulus, still there is no improvement. In these cases, we are giving calcium channel blockers. And can you tell me what are the agents given? We are giving diltiazem and nifedipine. So the agents given, diltiazem, we are giving diltiazem and nifedipine. So the agents are diltiazem and nifedipine. Nifedipine, clear? So these are the calcium channel blockers used in Raynaud's phenomena. Next is acute mesenteric ischemia. It's very, very important and it's very easy to understand. Just imagine this is one organ. Imagine this is an organ. Clear? So this is organ. In this case, you can see this is the arterial supply. Clear? And this is the venous drainage. So this is the arterial supply and this is the venous drainage, right? So what is the cause of mesenteric ischemia? Any organ is there. Suppose in the artery, what is the problem? If there is embolic occlusion. In the artery, if there is embolic occlusion, or in the artery, there is thrombosis, or in the artery, there is vasoconstriction. So what is the problem? There is impaired blood flow, is impaired blood supply to the organ. So what happens in the artery? If in the artery supplying the organ, there can be embolic occlusion. So what happens? There is embolic occlusion, right? There can be thrombosis, thrombosis, arterial thrombosis, right? And sometimes there can be vasoconstriction. In all these cases, there is impaired blood supply to the organ. So obviously there is ischemia. Similarly, imagine this is the vein, and in vein, what happens? There is venous thrombosis. So if in the vein there is venous thrombosis, because of venous thrombosis, what's the big problem? There is collection of deoxygenated blood and there is congestion in the organ. So this can also lead to ischemia. So what happens in mesenteric ischemia, acute mesenteric ischemia, it can be caused by embolic occlusion of artery, it can be caused by arterial thrombosis, it can be caused by vasoconstriction in mesenteric artery, that is known as non-occlusive mesenteric ischemia, and it can be caused by mesenteric venous thrombosis. Clear? So can you tell me what is the most common cause? The most common cause of acute mesenteric ischemia, that is embolic occlusion in 50% cases. So most common cause, it is embolic occlusion in 50% cases. And which artery is involved? Guys, there is involvement of superior mesenteric artery. So which artery is involved? It is superior mesenteric artery, right? Now, what is the source of embolus? Arrhythmia, right? You know, we discussed that if patient is having atrial fibrillation, in the left atrium there is formation of, yes, clot. And what happens? That clot is embolized. So arrhythmia, especially if the patient is having atrial fibrillation, right? Second, patients who are having valvular heart disease. Third, patients who are having MI. In MI, myocardial infarction, what's the big problem? There is mural thrombus. There is formation of mural thrombus, and again, it can lead to embolic occlusion. This can lead to embolic occlusion. First. Second cause is arterial thrombosis, and arterial thrombosis is responsible for 25% cases of acute mesenteric ischemia. How much? 25%. And guys, can you tell me what is the most common cause of arterial thrombosis? Yes, atherosclerosis. So it is caused by atherosclerosis. Third, it is non-occlusive mesenteric ischemia. Now, what is the problem? Why there is non-occlusive mesenteric ischemia we discussed? Because in the mesenteric artery, there is vasoconstriction. Clear question. Why there is vasoconstriction or spasm? Suppose a patient is having hypotension or shock. If patient is in the state of shock or hypotension, blood should be mainly going to the brain and the heart. That's why what happens? In mesentery, there is vasoconstriction. So these patients are actually having hypotension or shock. So because of hypotension or shock, there is vasoconstriction in the mesenteric vessels. So if there is vasoconstriction in superior mesenteric artery, what will happen? Obviously, because of vasoconstriction, because of spasm, the supply to bowel is affected. So this is non-occlusive mesenteric ischemia, and it is responsible for 5 to 15% cases. Responsible for 5 to 15% cases of acute mesenteric ischemia. So anything in which there is shock, like heart failure, pumping action of heart is gone, massive burns, because of massive burns there is hypovolemia or shock, sepsis, it can lead to septic shock. In acute pancreatitis also there is third space loss. In acute MI also it can lead to what? Non-occlusive mesenteric ischemia. Next is venous thrombosis. Venous thrombosis. You know that for venous thrombosis there is a triad which should be positive, and what's the name? Virchow triad. What are the components of Virchow triad? Endothelial injury, stasis of blood flow, and hypercoagulable state. Can you tell me out of these three which one is most important? So the most important is hypercoagulable state. So out of this, most important, it is hypercoagulable state. So whenever we will be treating the patients who are having venous thrombosis, what's the condition? Mesenteric venous thrombosis, you will notice that in the treatment, mainly we will be giving what? Anticoagulants. And since patient is having congenital or acquired hypercoagulable state, in majority of cases, we are going to continue anticoagulants even after surgery, even in the post-operative period. So this is the etiology of acute mesenteric ischemia. Now see the clinical presentation. First important point, since there is impaired blood flow to the bowel, so what will happen? Patient will be having severe abdominal pain. So severe abdominal pain, this is the most common symptom. Severe abdominal pain, this is the most common symptom. The clue of acute mesenteric ischemia, that here, the severe abdominal pain, it is out of proportion to physical examination findings. It means symptoms are out of proportion to examination findings. Lots of signs are not there, right? So what is the problem? There is ischemia. Another thing, patient will be having persistent vomiting and diarrhea. There is melena and hematochezia. You know why there is melena and hematochezia? The lining of bowel, the epithelium, it is very sensitive to ischemia. So whenever there is ischemia, what will happen? There is necrosis and there is sloughing. So whenever there is necrosis, there is sloughing of epithelium. What will happen? There is bleeding. So patient will be having bleeding manifestation like melena and hematochezia. In what percentage? In approximately 15% cases. So in approximately 15% cases, there is melena, there is hematochezia. And in late stages, see the sequence, what will happen? Initially, there is ischemia. If there is delay in diagnosis or if there is delay in the treatment, what will happen? It can progress to gangrene. If still there is delay, what will happen? It leads to sepsis. And after sepsis, what will happen? Yes, it can cause shock. It can cause shock. So ultimately, what will happen? In late stages, patient might present to your emergency in the state of shock. Next, where is the problem? In acute mesenteric ischemia, we discussed that embolic occlusion of superior mesenteric artery, that's the most common cause in 50% cases. So if you want to assess mesenteric artery, obviously you have to go for mesenteric arteriography. So what is the investigation of choice? Yes, it is mesenteric arteriography. What we are going for? Mesenteric, it is mesenteric arteriography. Mesenteric arteriography, right? Suppose a patient is having non-occlusive mesenteric ischemia. What is the problem? Here, there is spasm of vessels, spasm of branches of superior mesenteric artery. Clear? So, if it is non-occlusive mesenteric ischemia, you are doing mesenteric arteriography. Can you see? You can notice that these areas, these are areas of contraction. So, you can notice the contracted vessel. In between, you can see appearances like sausage. So, what is the name of this sign? Especially in non-occlusive mesenteric ischemia, this is known as string of sausages sign. So what's the name? Guys, this is very important. On mesenteric arteriography, in non-occlusive mesenteric ischemia, what's the name? This is string of sausages sign. Clear? So this is string of sausages. So you can see here, this is string of sausages sign. Diagnosis is done. After that, you have to manage. In this case, the most important thing is early diagnosis. Why? Because delay in diagnosis can cause gangrene of bowel. So early diagnosis is the most important aspect. After that, we go for aggressive resuscitation. And let me tell you, this resuscitation is done in OT. So we take the patient directly to OT and we start resuscitation in the OT itself. So what we give? Obviously, we give IV fluids. In the OT itself, we give IV fluids and IV antibiotics. So aggressive resuscitation is done in OT. Imagine, patient is having non-occlusive mesenteric ischemia. What is the cause? We discussed that it is because of spasm of mesenteric vessels. So in this case, we go for early revascularization. What is done here? In non-occlusive mesenteric ischemia, we go for early revascularization. And how this early revascularization is done? We are going to inject papaverine. So catheter-directed papaverine infusion into superior mesenteric artery. And it is going to relieve the spasm of mesenteric vessels. So how early revascularization is done? It is catheter-directed. Here what we do? We go for catheter-directed papaverine infusion into superior mesenteric artery. Catheter-directed papaverine infusion. Clear? So catheter-directed papaverine infusion into superior mesenteric artery. Infusion into superior mesenteric artery, and it is going to relieve the spasm of mesenteric vessels. Right? Another situation, imagine patient is having mesenteric venous thrombosis. What is the problem in venous thrombosis? We discussed triad should be positive, virtuose, endothelial injury, stasis, hypercoagulable state. So you have to stop the propagation of thrombus. So in this case, what you start? In this case, we have to start anticoagulants. So in mesenteric venous thrombosis, what we give? We give anticoagulants. So anticoagulants are given because the most important thing is what? Hypercoagulable state. So to prevent the propagation of thrombus, start anticoagulants. So there are two presentations in acute mesenteric ischemia. First, some patients are brought early to the emergency. So obviously, if patient is brought early, there is absence of peritonitis. And if there is absence of peritonitis, early diagnosis and aggressive resuscitation. So supportive care. Second, papaverine infusion. And it is done for which patients? The patients who are having non-occlusive mesenteric ischemia. And third option, we go for anticoagulants. Anticoagulants are given in the patients who are having mesenteric venous thrombosis. But imagine there is late presentation. Why? Because after ischemia, there is gangrene. After that, there is perforation. So because of perforation, patient is having peritonitis. If patient is having peritonitis, obviously we are not left with anything. We have to take the patient to OT. So after resuscitation, perform the exploratory laparotomy, and whatever necrotic bowel is there, we have to resect it. So this is how we manage the patients who are having acute mesenteric ischemia. Now we are going to discuss mesenteric venous thrombosis. We discussed that it is responsible for acute mesenteric ischemia. What percentage of? Responsible for 5 to 15% of acute mesenteric ischemia, right? Let me tell you one important point. In acute mesenteric ischemia, most commonly involved artery, superior mesenteric artery. In mesenteric venous thrombosis, most commonly involved vein, superior mesenteric vein. So here, most commonly involved vein, that is superior mesenteric vein. Inferior mesenteric vein, relatively, it is spared. This is spared. Clear? Now, what is the problem here? Here also, the manifestations will be very similar to acute mesenteric ischemia. Like, patient will be having severe abdominal pain. That is the most common symptom, and it is out of proportion to the signs. This severe abdominal pain, it is going to persist for 2 to 3 hours. It is going to persist. So, severe abdominal pain, it is going to persist for 2 to 3 hours. Just like acute mesenteric ischemia, here also there is melena and hematochezia in approximately 15% cases. In approximately 15% cases, melena and hematochezia, and we discussed that if there is delay in presentation, so in late stages, initially there is ischemia, followed by gangrene, followed by sepsis, followed by shock. So in late stages, patient might be brought to your emergency in the stage of shock. Here, how to make the diagnosis? Because of mesenteric venous thrombosis, there is congestion of mesentery. And since there is congestion of mesentery, this is extraluminal condition of GIT. And we discussed that extraluminal conditions of GIT like GIST, mesenteric cyst, mesenteric venous thrombosis, intra-abdominal collection, intra-abdominal abscess. In all these cases, what is the investigation of choice? CCT. So here also, investigation of choice for diagnosis, it is CCT. Clear? So remember, for acute mesenteric ischemia, whenever there is occlusion of superior mesenteric artery, we go for mesenteric arteriography. In mesenteric venous thrombosis, we go for CCT. Here, the most important step after resuscitation is rapid initiation of systemic anticoagulants. So what we start giving heparin intraoperatively. So heparin is started intraoperatively. So heparin, it is started intraoperatively. Intraoperatively, we have to start heparin. Why? Because we want to stop the propagation of thrombus. Second, anticoagulation should be continued in postoperative period or not. Now see here, we discussed that in Virchow's triad, 3 components are there. Endothelial injury, stasis and hypercoagulable state. We discussed that in mesenteric venous thrombosis, the most important component is what? Hypercoagulable state. Actually, most patients are having inherited or acquired hypercoagulable state. And that's why you have to continue anticoagulants even in postoperative period. Why? Because if you're not going to continue, you can't believe how much is the risk of recurrence, 35 to 70%. That's why anticoagulants are continued postoperatively. In this case, anticoagulants, these are continued in the postoperative period. Why it is continued in postoperative period? Because, you know, the risk of recurrence, this is very important. How much? The risk of recurrence, it is 35 to 70%. So in mesenteric venous thrombosis, risk of recurrence, it is 35 to 70. Why? Because these patients are having what? Coagulation, hypercoagulable state, which can be inherited or acquired. Suppose patient is having peritonitis. So obviously, in cases of peritonitis, we have to go for exploratory laparotomy. So if patient is having peritonitis, we go for exploratory laparotomy. How much is the mortality rate? In patients of mesenteric venous thrombosis, you can't believe, up to 50%. The mortality rate is relatively lower in comparison to embolic occlusion of superior mesenteric artery, but it is up to 50%. Next is chronic mesenteric ischemia. What is the cause? Most common cause. In these cases, actually, patient is having advanced atherosclerosis. And this advanced atherosclerosis is not only involving one vessel, it is involving multiple mesenteric vessels. It means there is involvement of both superior mesenteric artery as well as inferior mesenteric artery. So in chronic mesenteric ischemia, the most common cause, it is advanced atherosclerosis. This is advanced atherosclerosis. Clear? Advanced atherosclerosis involving multiple mesenteric vessels means here there is involvement of both. There is involvement of both superior mesenteric artery plus inferior mesenteric artery, right? Actually speaking, it's a rare condition. Why? Because you know that there are various collaterals which are going to exist between superior mesenteric artery and inferior mesenteric artery. So because of extensive collateral network in the mesentery, It's rare. Why? Because there is extensive collateral network. So there is extensive collateral network. Because of that, this condition is rare, right? What is the most important factor here? Atherosclerosis. It means any risk factor for atherosclerosis, obviously, it will be indirect risk factor for chronic mesenteric ischemia. So here you can see what are the risk factors. First, positive family history, hypertension. Apart from this, you can see smoking and hypercholesterolemia. You know, smoking and hypercholesterolemia, these are the risk factors for atherosclerosis also. And that's why these are the risk factors for chronic mesenteric ischemia. Now, what is the problem? It's chronic mesenteric ischemia, right? So these patients after meals, what happens? What happens after meals? The normal physiology. After meals, there should be increased blood flow to the bowel. Why? For digestion and absorption. So after meal, there should be increased blood flow. But what is the big problem? Because of atherosclerosis involving both superior mesenteric artery as well as inferior mesenteric artery, after meals, yes, the supply is not sufficient. Demand is too much, but supply is not sufficient. So what will happen ultimately? Patient is having ischemia. And if there is ischemia, what's the problem? Pain. So when pain occurs mainly, is the postprandial abdominal pain. And this is going to last for 15 to 45 minutes. It is going to last for 15 to 45 minutes of meals. It is going to last for 15 to 45 minutes of meals. Clear? Why? Because of mesenteric ischemia. And what kind of pain? Yes, it is diffuse cramping pain. We discussed intermittent claudication. What happened in intermittent claudication? We discussed Burgess in part 1. So in Burgess, during work or exercise in muscles, there is impaired supply. If sufficient supply is not there, in the muscle there is ischemia, and because of ischemia there is what? Cramping pain. So here also there is cramping pain. So that was intermittent claudication. Similarly, this is known as intestinal claudication. Intestinal claudication. Because of ischemia there is a pain. There is pain. So this is also known as intestinal angina. So these questions were asked multiple times. Yes, intestinal angina. What is the other name of chronic mesenteric ischemia? Yes, intestinal claudication. What kind of pain? Diffuse cramping pain. Now see the problem. Whenever patient is having meals, patient is having diffuse cramping pain. And after that, patient is having this kind of thought that whenever I will be having meals, I will be having pain. So patient is having fear of food. Patient start avoiding the food. And because of this, what is the big problem? It leads to weight loss. So there is fear or aversion of food. Because of this, patient will be having weight loss. Now, how to make the diagnosis? Duplex scan is done. Why we go for duplex scan? Because we want to assess the flow and anatomy of mesenteric vessel. So duplex scan because we want to assess the flow. So we want to assess the flow and anatomy. So we want to assess the flow and anatomy of mesenteric vessels. Mesenteric vessels. Mesenteric vessels. Clear? We go for duplex scan. But investigation of choice for diagnosis, it is aortography. Aortography. Because in atherosclerosis, there is involvement of aorta. So we want to assess that which part of superior mesenteric artery, which part of inferior mesenteric artery is involved. What is the extent of atherosclerosis? So 3 questions which are asked. First, investigation of choice for diagnosis of acute mesenteric ischemia. Problem is in the superior mesenteric artery. So it is mesenteric arteriography. Investigation of choice for diagnosis of mesenteric venous thrombosis. We discussed CCT. And investigation of choice for diagnosis of chronic mesenteric ischemia, that is aortography. Clear? So here what we do? We go for revascularization. Why? Because there is occlusion. So in elderly, how you go for revascularization? In elderly, we can go for balloon angioplasty or we can insert the stent. So options are, we can go for balloon angioplasty, or second option, we can go for stent. So stent placement. So balloon angioplasty or stent placement. Stent placement. What is the definitive treatment? Obviously, in definitive treatment, we go for transaortic endarterectomy because there is occlusion, or we can go for bypass grafting if there is occlusion. So definitive treatment, transaortic endarterectomy or bypass grafting in chronic mesenteric ischemia. First, see the normal anatomy. Tell me guys, what are the branches of arch of aorta? Can you see here? Arch of aorta. This is brachiocephalic. Brachiocephalic artery, what are the branches? You can see this is right common carotid and this is right subclavian. So this is right common carotid, this is right subclavian. There is a branch of right subclavian. What's the name? You can see right vertebral artery. Similarly, The second branch is, this is left common carotid, and this is the third branch. This is left subclavian, right? Left subclavian. So left subclavian gives this left vertebral artery. So you can see right and left vertebral artery, it is going to form basilar artery. Basilar artery, it is going to supply the posterior circulation of brain, that is cerebellum, and what else? Occipital cortex. And this circulation is known as vertebro-basilar circulation, also known as posterior circulation of brain, right? Now coming to the questions. First, what is the most common cause of subclavian artery stenosis? We discussed that in majority of arterial disorders, the most common cause is atherosclerosis. So most common cause of extracranial aneurysm, most common cause of peripheral arterial occlusion, most common cause of subclavian artery stenosis, and most common degenerative disorder of vessel, atherosclerosis. So here, most common cause is atherosclerosis. One thing is clear? It is atherosclerosis. Next, can you tell me most commonly involved vessel? It is subclavian artery, obviously. Which one? Left or right? So it is left subclavian artery. It is more commonly involved than right subclavian artery. Next, in left subclavian artery, which part? Yes, so it is first part. What's the part? It is first part. So what is that first part? You can see first part of left subclavian artery. So actually, it is just distal to origin of subclavian artery. Can you see? This is the origin. So it is just distal to origin of subclavian artery. You can see here. And obviously, it is proximal to origin of left vertebral artery. So distal to origin of left subclavian artery, proximal to origin of left vertebral artery. Subclavian artery stenosis. Now, what is the problem? In this image, you can notice, where is the stenosis? You can see the stenosis, right? Just, you can see, just distal to origin of subclavian artery, left subclavian artery, and it is proximal to origin of what? Vertebral artery. Now see, I'm performing or I'm doing some work or exercise by left upper limb. You know that during work or exercise, the muscles which are working or exercising, yes, they need too much of blood supply. That's why the arteries which are supplying the muscles undergoes vasodilatation. So artery undergoes vasodilatation. Because of that, there is low pressure zone, and that's why there should be increased blood flow. So during work or exercise, there is increased demand of blood for the working or exercising muscle. But what is the problem? You can see this left subclavian artery, it is not going to provide the blood because there is stenosis during work or exercise. So what will happen? There is reversal of blood flow in ipsilateral vertebral artery. So blood is being stolen from the brain. Blood is being stolen from the brain to feed the working or exercising arm. That's why what's the name? Obviously, subclavian steal syndrome. So blood is being stolen from brain to supply the working or exercising arm. So what will happen? There is reversal of blood flow. Where? Remember, in ipsilateral vertebral artery. It occurs in ipsilateral vertebral artery. Because of that, what will happen? There is ischemia of posterior circulation. Good thing, most of the patients are asymptomatic. So that's why there is transient vertebro-basilar ischemia. But in severe cases, patient might be symptomatic. And obviously, what kind of symptom? There is ischemia of cerebellum. There is ischemia of occipital cortex. So the symptoms will be seen. In cases of severe stenosis, so there will be weakness, there might be syncope, vertigo, there might be imbalance, ataxia, dizziness, and since there is involvement of occipital cortex, so what will happen? Visual abnormalities. So these are the clinical manifestations of subclavian steal syndrome. So what you have to remember, which is most important, reversal of blood flow occurs in contralateral vertebral artery or ipsilateral vertebral artery. Yes, it is ipsilateral vertebral artery. Now we are going to discuss aneurysm. First, what is the difference between aneurysm and ectasia? In aneurysm, there is irreversible localized dilatation of blood vessel with at least, remember this, at least 50% increase in the diameter. And if it is less than 50%, if dilatation of blood vessel is occurring, but there is less than 50% increase in diameter, that is ectasia. So aneurysm, at least 50% increase in the diameter. Ectasia, there is less than 50% increase in the diameter. Now see important questions related to aneurysm. Can you tell me what is the most common vessel involved in aneurysm? Obviously, circle of Willis. What is the most common location of extracranial aneurysm? Infrarenal aorta. So first, most common vessel involved in aneurysm. This is circle of Willis. This is circle of Willis. Clear? Next, most common location of extracranial aneurysm. This is infrarenal aorta. So this is infrarenal aorta, means abdominal aorta. So it is infrarenal aorta. After that, second most common, iliac artery. So this is what? Iliac artery. After that, popliteal artery. After that, femoral artery. So popliteal artery. It is popliteal artery. After that, femoral artery. Clear? So it is popliteal artery. After that, femoral artery. Clear? So how to remember, guys? It's very easy. Can you see? Aorta, followed by iliac artery, followed by popliteal artery, followed by femoral artery. So mnemonic is All India Police Force. AIPF, you can see. It is All India Police Force. AIPF. Next, there is another answer hidden in this mnemonic. All India Police Force. Can you tell me what is the most common site of peripheral arterial aneurysm? Peripheral, and that artery also starts with P. Peripheral, popliteal. So most common site of peripheral arterial aneurysm, it is popliteal. Popliteal. It is popliteal artery. Next question. Most common site of splanchnic. This is also known as visceral. Splanchnic or visceral. So splanchnic or visceral arterial aneurysm. Splanchnic, it also starts with S. Splanchnic, splenic. Splanchnic, splenic. So how to remember? Splanchnic, splenic. So it is splenic artery. Splenic artery. Next, what is mycotic aneurysm? It is not caused by fungus. It's not because of fungal infection. It's a misnomer. See, can you tell me which artery is being used by cardiologists also, radiologists also, or interns also sometimes when they are not able to withdraw the blood for sampling? Yes, femoral artery. And if you are not going to clean that area, what happens? During puncturing femoral artery, you might introduce some organism from the skin. Can you tell me which organism? Staph. So most common artery involved. Yes, femoral artery followed by aorta, and most common organism, it is Staph aureus followed by Salmonella. So important question, what is the most common site of mycotic aneurysm? Yes, femoral artery. This is femoral artery. Femoral artery followed by aorta. Femoral artery followed by aorta. Most common organism, Staph aureus followed by Salmonella. Next important question, what is the most common cause of abdominal aortic aneurysm? We discussed atherosclerosis. So most common cause, that is atherosclerosis. Clear? The most common cause is atherosclerosis. And the risk of rupture, if you see, in aortic aneurysm, the risk of rupture, it is directly proportional to width or diameter. Can you see here? This is width. So this is width or diameter. So risk of rupture is directly proportional to or directly related to what? Width or diameter. It's width or diameter. Width or diameter. Okay, one question. Second question, you know that aorta is on the left side, and on the right side you can find that this is IVC. This is inferior vena cava. So inferior vena cava is on the right side. Suppose there is rupture of aortic aneurysm. So obviously it is going to rupture on which side? Right side or left side? There is free space on the left side. So it is going to rupture on the left side. You know, aorta is located in retroperitoneum. So what kind of rupture will occur? It is left retroperitoneal or left intraperitoneal? Obviously, left retroperitoneal. So first question, most common site of rupture, it is left retroperitoneal. Second important question, how much is the mortality in cases of ruptured aortic aneurysm? If you see the mortality associated with ruptured aortic aneurysm, this is more than 50%. Ruptured aortic aneurysm mortality, it is more than 50%. It means it is just like a time bomb. If it is detected early, you should diffuse it before it's going to rupture or before it is going to blast. So what is the protocol? Remember, whenever we are performing investigation and suppose we are going to make the diagnosis of aortic aneurysm, what happens? There is a cutoff diameter before which you should perform the surgery. So what is the cutoff diameter for surgery? In cases of descending thoracic aorta, diameter should be more than equal to 6.5 centimeter. In cases of abdominal aorta or ascending aorta, diameter should be more than equal to 5.5 centimeter. In cases of iliac artery, it should be more than equal to 3.5 centimeter. In cases of femoral artery as well as popliteal artery, diameter should be more than equal to 2 centimeter. 2 centimeter. Which question is most commonly asked? They ask you the cutoff diameter for surgery in cases of abdominal aorta. In cases of abdominal aortic aneurysm, it is more than equal to 5.5 centimeter. So guys, how to remember? You have to remember descending thoracic aorta more than equal to 6.5, abdominal aorta, ascending aorta more than equal to 5.5, iliac artery more than equal to 3.5. There is a clue. So how to remember? For most of the medium-sized vessels, for medium-sized vessels, the cutoff diameter is more than equal to 2 centimeter. And if you see, for most of the small-sized vessels, the cutoff diameter is more than equal to 1 centimeter. So for small-sized vessels, cutoff diameter is more than equal to 1 centimeter. For medium-sized vessels, cutoff diameter is more than equal to 2. Small-sized vessels, cutoff diameter is more than equal to 1. Now see a cut section of vessel. What are the layers? Layers you can see inside is intima, then there is media, and outside you can see there is adventitia. So these are the layers of blood vessel. Now definition, what is true aneurysm? What is false aneurysm? You know true diverticula, false diverticula. So in bowel, when all three layers are involved, it is true diverticula, and false diverticula when all three layers are not involved. Similarly, in aneurysm, when all three layers are involved here, that is true aneurysm, and when all three layers are not involved, that is false aneurysm. Now see this is saccular aneurysm. What you can notice that it is going to affect only one part of circumference. So if there is involvement of one part of circumference only, it is saccular. You can notice that all three layers are involved. So this is true aneurysm or false? True aneurysm, but it is saccular. It is involving only part of circumference. What is the big problem with saccular aneurysm? Yes, irrespective of size, there is high risk of rupture. You can see the second one. This is fusiform. So in this case, you can notice that all three layers are involved and there is dilatation of whole circumference. Whenever there is symmetrical enlargement involving the whole circumference, this is fusiform. And in this case also, you can notice that all three layers are involved. So can you tell me this is true or false? So both fusiform as well as saccular, these are true aneurysm. Next, you can notice in this image, you can notice that there is tear in the intima. After that, you can notice that the blood is going to enter into intima media space. And because of that, it is going to cause the dissection. And after that, what happens? There is dilatation, clear aneurysmal dilatation of this false lumen. So why? It is known as dissection aneurysm because initially there is dissection by the blood of intima media space. Following, after that, there is dilatation of false lumen. So what's the name? This is known as dissection aneurysm. So there are two components. First, there is dissection with aneurysmal dilatation of false lumen. So dissection with aneurysmal dilatation of false lumen. Aneurysmal dilatation, clear? So whenever there is dissection followed by aneurysmal dilatation of false lumen. False lumen. Next, you can notice that false aneurysm, in this case, you can see that all three layers are not involved. Here you can notice that only two layers are involved. So since all three layers are not involved, that is false. So true, all three layers are involved. False, all three layers are not involved. Secular, only one part of circumference of bowel is involved. When uniform dilatation occurs involving all three layers, it is fusiform. And you know, atypical aneurysm, secular aneurysm, dissection aneurysm, false aneurysm, pseudoaneurysm. So secular, dissection, false or pseudoaneurysm, irrespective of size, these are having high risk of rupture. Now we are going to discuss the important questions related to abdominal aortic aneurysm. So first tell me, what is the most common site of abdominal aortic aneurysm? You know, it is infrarenal aorta. Clear? So that is infrarenal aorta. Infrarenal aorta. Next question, what is the most common site of atherosclerosis? And you know, it is same, infrarenal aorta. So if the most common site of atherosclerosis is also same, there must be some relation between abdominal aortic aneurysm and atherosclerosis. What? That the most common cause of abdominal aortic aneurysm, we discussed, it is atherosclerosis. So this is atherosclerosis, clear? So this is atherosclerosis. Next, what is the most common symptom? First tell me, what is the location of aorta? Retroperitoneum. So these patients are having chronic, vague abdominal pain, or the patients are having back pain. So most common symptom, these patients are having chronic, vague abdominal pain. So chronic, vague abdominal pain or back pain. So chronic, vague abdominal pain or back pain. Back pain. We already discussed that what is the most common and most lethal complication of aortic aneurysm, abdominal aortic aneurysm. We discussed its rupture. Its rupture. And what is the most important predictor of rupture? Yes, it is width or diameter. It is width or diameter. That's the width or diameter. And most common site of rupture, yes, you told me, left retroperitoneal. And how much is the mortality associated with ruptured abdominal aortic aneurysm? More than 50%. What is the triad of abdominal aortic aneurysm? Rupture, triad of abdominal aortic rupture. See, it is not seen in all cases, only seen in 1/3 of cases. So these patients are having sudden onset of mid-abdominal or flank pain. Sudden onset of mid-abdominal or flank pain since there is aortic aneurysm rupture. So obviously patient will be in the state of shock, and these patients are having pulsatile abdominal mass. So triad of abdominal aortic aneurysm rupture, sudden onset of mid-abdominal or flank pain, there is shock and pulsatile abdominal mass. Not seen in all cases, it is only seen in 1/3 of cases. It is only seen in 1/3 of cases. Now see the investigations done in cases of abdominal aortic aneurysm. X-ray. On X-ray, we are going to find eggshell pattern of calcification. So what's the pattern of calcification seen on X-ray? Remember, it is eggshell pattern. So that is eggshell pattern of calcification. So there is eggshell pattern of calcification on X-ray. Calcification on X-ray. In one of the latest exams, this question was asked that investigation of choice for screening of abdominal aortic aneurysm. Obviously, we go for ultrasound. Cheap, easily available, safe, having good sensitivity and specificity, ultrasound. Now, the question was, suppose on ultrasound you detected aneurysm in a patient. Location was abdominal aortic aneurysm, infrarenal aorta, involving infrarenal aorta, size 4 cm. So what will you do? Obviously, we will follow this patient up, follow up this patient with ultrasound, and whenever size is achieved, what's the size? Cutoff diameter, more than equal to 5.5 cm. So whenever size is achieved 5.5 cm, we go for elective repair. So for screening, we are using ultrasound. Next, investigation of choice for diagnosis and planning the repair. You know that for retroperitoneum, which investigation is preferred? CCT. So here we go for CCT. But in CCT, we are giving contrast. So if patient is having renal failure, for that investigation of choice for diagnosis and planning repair of abdominal aortic aneurysm in patients who are having renal failure, in this case, we go for MRI. So what we do? MRI if patient is already having renal failure. Now see the indications of surgery in abdominal aortic aneurysm. These indications are very important, asked frequently. We discussed diameter. How much? More than equal to 5.5 cm. Or patient is having symptomatic aneurysm irrespective of size. If the rate of expansion is more than 1 cm per year, remember, rate of expansion more than 1 cm per year, or patient is having atypical aneurysm. We discussed what are those atypical aneurysm: dissection aneurysm, pseudoaneurysm or false aneurysm, and saccular aneurysm. So irrespective of size, in atypical aneurysms, what happens? There is increased risk of rupture. Irrespective of size, since there is increased risk of rupture, so what? In these cases, we go for surgical intervention, surgery, and how to remember? Mnemonic is DPS. It is DPS. So this is DPS, dissection aneurysm, pseudoaneurysm, saccular aneurysm. Irrespective of size, we are going for surgery. Now, what kind of repair is done? Obviously, in abdominal aortic aneurysm, we use Dacron graft. So Dacron graft repair, we have two options. Either we can go for endovascular aneurysm repair, that is EVAR, endovascular aneurysm repair, or we can go for open repair. In open repair, we have two approaches. One is transperitoneal, second is retroperitoneal. First tell me which one is preferred. Transperitoneal is preferred. But if patient is having horseshoe kidney or patient is having history of previous abdominal surgery, in those cases, we go for retroperitoneal approach. So EVAR, endovascular aneurysm repair, or open. What is the preferred approach? It is the transperitoneal approach. In horseshoe kidney, or if there is history of previous abdominal surgery, we are going for retroperitoneal approach. So here you can see how we are going to perform the repair. First, you have to open the aneurysm. So you are going to open the aneurysm wall. After opening the aneurysm wall, you have to use the Dacron graft. So you perform the vascular anastomosis. After vascular anastomosis, you are going to cover the graft with wall of aneurysm. So you can see we are going to cover the graft with this wall of aneurysm. So this is Dacron graft repair of abdominal aortic aneurysm, and you can see the typical location, infrarenal aorta. It is involving infrarenal aorta. Now see the important questions. How much is the mortality rate if you are going for elective abdominal aortic aneurysm repair? It is less than 5%. If it is elective abdominal aortic aneurysm repair, but if there is ruptured abdominal aortic aneurysm, in that case, how much is the mortality rate? Is more than 50%. More than 50%. And what is the most common cause of death after abdominal aortic aneurysm repair? What happens? There is massive blood loss. What happens? So much of fluid exchange. So these patients are already having what? Atherosclerosis, might be having coronary artery disease. Patients are going to expire because of myocardial infarction. So that's the most common cause of death. If we talk about the most common complication after abdominal aortic aneurysm repair, that also is MI, but this is non-fatal. So most common complication, it is non-fatal MI, non-fatal myocardial infarction followed by renal failure. So it is non-fatal MI followed by renal failure, Now see the other complications. There can be bleeding, there can be graft leak. What is the cause of paraparesis after abdominal aortic aneurysm repair? It is because of injury of one artery. What's the name? Remember this name, arteria radicularis magna, also known as artery of Adam-Key-Weeks. It is because of injury of arteria radicularis magna. This is arteria radicularis magna. Clear? So arteria radicularis magna. This is also known as artery of Adam-Key-Weeks. Remember this? Adam-Key-Weeks. Clear? So this is Adam-Key-Weeks. Artery of Adam-Key-Weeks. What's the problem? This is the main artery that supplies the anterior spinal artery. And you know that anterior spinal artery, it is going to supply the thoracolumbar segment of spinal cord. So paraparesis, it is because of injury of arteria radicularis magna, also known as artery of Adam-Key-Weeks. There can be infection, there can be colonic ischemia. So these are the other complications of aortic aneurysm repair. Now see the next. There is a classification system for thoracoabdominal aortic aneurysm. This is thoracoabdominal aortic aneurysm. And what's the name? This is modified Crawford classification. See the modified Crawford classification. So what is type 1? You can see the extent in type 1 from left subclavian artery till suprarenal aorta. So type 1 extent from left subclavian artery till suprarenal aorta. In type 2, the extent you can see from left subclavian artery till aortoiliac bifurcation. And here you can notice that this is most extensive. You can notice that almost whole thoracoabdominal aorta is involved. So this is most extensive, type 2. In type 3, you can see the extent. It is from distal thoracic aorta till aortoiliac bifurcation. Type 4, you can notice that it is limited to abdominal aorta, type 4. And in type 5, what is the extent? From distal thoracic aorta till superior mesenteric artery. So this is modified Crawford classification for thoracoabdominal aortic aneurysm. Let's revise quickly. Type 1, from the origin of left subclavian artery till suprarenal aorta. Type 2, from left subclavian artery till aortoiliac bifurcation, and we discussed. This is most extensive. Type 2, it is most extensive. Now you can see the type 3, from distal thoracic aorta till aortoiliac bifurcation. Type 4, limited to abdominal aorta. Type 5, from distal thoracic aorta till superior mesenteric artery. We already discussed mycotic aneurysm, that it's a misnomer. It is not caused by fungal infection. Here, there is focal dilatation of arterial wall which is weakened by infection. And we already discussed which artery, which is used by interns, cardiologists, radiologists, femoral artery. So most commonly involved artery, it is femoral artery followed by aorta. So it is femoral artery followed by aorta. And if you're not going to clean the area, yes, when you are going to puncture the femoral artery, you are going to introduce the infection from skin into the artery. So obviously the organism is staph followed by salmonella. So it is staph followed by salmonella. So the organism is staph followed by salmonella. In this image, you can notice that here, focal dilatation of arterial wall weakened by infection, name mycotic aneurysm. Now see this image. In this temporal region, you are going to notice that there is mass. What kind of mass is this? It is slow growing pulsatile mass in this temporal region. What is the name? Sarcoid aneurysm. What is a better term for this condition actually? It is AV malformation. So this is rare AV malformation of scalp. It is fed by which artery? Can you tell me? See the region. Obviously it is superficial temporal artery. So fed by superficial. It is fed by superficial temporal artery. What is the presentation? Superficial temporal artery. Since it is AV malformation, this patient comes to you, patient tells you that what? Patient is having pulsatile mass. So this is slow growing pulsatile mass. Presentation. there is slow growing pulsatile mass. Actually speaking, it's a AV malformation. Slow growing pulsatile mass. If it is AV malformation, so obviously we can go for embolization or endovascular occlusion, or since it is fed by superficial temporal artery, we can go for surgical resection, or we can directly inject sclerosing agent into this AV malformation. So this is how we manage the patients who are having sarcoid aneurysm. Sometimes image-based question is asked, and sometimes they ask which artery is responsible for sarcoid aneurysm. It is superficial temporal artery. Now we are going to discuss aortic dissection. What happens in aortic dissection? You can see that there is transverse or circumferential tear in the intima. You can see here, this kind of tear is there. So transverse tear is there in the intima. After that, you can notice that the blood is going to enter into intima media space. So after that, the blood is going to enter into intima media space. Already what is the problem? In aorta, there is too much of pressure. So blood enters with pressure. And if blood is going to enter with pressure, what happens? It is going to cause the separation of inner and medial layer. So it leads to aortic dissection. So what is the problem here? There is transverse tear. Because of that, blood is going to enter into intima media space. And since blood enters under pressure, because of that, there is dissection of aorta leading to separation of inner and middle layer. So questions, what is the most common site of aortic dissection? The most common site is right lateral wall of ascending aorta. This is right, most common site, that is right lateral wall, right? So it's the right lateral wall of ascending aorta. So it is the right lateral wall of ascending aorta. This is ascending aorta. And you know, aortic dissection, it is more common in males. In which particular age group it is seen? It is seen in 6th to 7th decade. It is seen in 6th to 7th decade. 6th to 7th decade. Can you tell me what is the most important risk factor for aortic dissection? The most important risk factor, that is systemic hypertension. So if you see the most important risk factor, that is systemic hypertension. This is most important. Apart from that, the other risk factors are cystic medial necrosis, and it is also common in 3rd trimester of pregnancy. So systemic hypertension, cystic medial necrosis, 3rd trimester of pregnancy, all these are the risk factors. Most important is the systemic hypertension. Systemic hypertension. What are the questions which are asked in exam? They ask classifications of aortic dissection. There are two types of classification. One is DeBakey and the second is Stanford. First, see the DeBakey classification. If you see this DeBakey classification, DeBakey type 1. DeBakey type 1, it is responsible for 60% cases. It means this is the most common type. And in this case, you can notice that there is intimal tear. Where? In ascending aorta. So you can notice that intimal tear is there in ascending aorta. So in ascending aorta, there is intimal tear and it is extending to descending aorta. So intimal tear in ascending aorta and it is extending to descending aorta. This is DeBakey 1. You can see DeBakey 2. In DeBakey 2, you can notice that the dissection is just limited to ascending aorta. Can you notice here that this dissection, aortic dissection, it is just limited. It is just limited to ascending aorta. So this is DeBakey type 2. It is limited to ascending aorta. You can see here, it is just limited to ascending aorta. Ascending aorta. And in type 3, you can notice that there is intimal tear. Can you see here? This is the intimal tear. So intimal tear is there in descending aorta and you can notice that there is distal propagation. So intimal tear is there in descending aorta. Intimal tear is there in descending aorta with distal propagation. With distal propagation, this is type 3. Distal propagation. So you can see type 1, there is intimal tear in ascending aorta till it is extending to descending aorta. Type 2, and in DeBakey 2, you can see that the aortic dissection is limited to ascending aorta, and in type 3, there is intimal tear in descending aorta with distal propagation. So this is DeBakey classification. You know that DeBakey 1 and DeBakey 2, this is included in Stanford A. So this Stanford A, this is proximal, and DeBakey type 3, this is Stanford B, that is distal. One thing you can notice here, that mainly which part of aorta is involved? The part of aorta which is located in thorax. That's why whenever patient is having aortic dissection, these patients will be having symptoms mainly confined to thorax. So most of the symptoms here are related to thorax. So what is the problem? You can see here the classification. DeBakey type 1, intimal tear in ascending aorta we discussed with extension to descending aorta. Type 2, it is just limited to ascending aorta, and type 3, there is intimal tear in descending aorta with distal propagation. Stanford A, that is 1 and 2, and Stanford B, that is type 3. Stanford A, this is proximal, Stanford B, that is distal. So this is DeBakey classification and Stanford classification. Next, there is chest pain. What kind of chest pain? Patient will be having sudden onset of severe chest pain. And what happens? It is going to radiate to interscapular region. Whenever you are going to get the question related to aortic dissection, generally this symptom is there in the question. Sudden onset of severe chest pain and radiating to interscapular region. Another characteristic feature, what? That there is migration of pain. Why there is migration of pain? Tell me. Migration of pain occurs with propagation of dissection. So why there is migration? Migration of pain occurs with propagation of dissection. So whenever there is propagation of dissection, there is migration of pain. Migration of pain. Apart from that, patient will be having syncope, there is dyspnea, weakness, and what happens? It leads to hypotension or shock. So these are the clinical manifestation. We discussed that since the part of aorta which is located in thorax, mainly thoracic aorta is involved. Here, you saw the symptoms are related to thorax. Next, if you go for chest x-ray, what you're going to find? Widened or widening of superior mediastinum. So on chest x-ray, there is widening of superior mediastinum. Widening of superior mediastinum. Second, these patients are having pleural effusion. Can you tell me on which side you are going to find pleural effusion? Obviously, aorta is located on the left side of chest. So apart from that, you are going to find left-sided pleural effusion. So what? We are going to find left-sided pleural effusion, right? Tell me, what is the investigation of choice for diagnosis of aortic dissection? If patient is stable, in that case, we go for CT angio. But if patient is unstable, in that case, we go for transesophageal echocardiography. You have to remember both. Stable patient, we go for CT angio. And what is the definition of unstable patient? When pulse rate is more than 100 per minute, BP less than 100 mmHg. Unstable patient, we go for transesophageal echocardiography. It is transesophageal echocardiography. And guys, see the updated management of aortic dissection. We discussed that. What is the most important risk factor? Systemic hypertension. So what is the initial management? It's the BP control, blood pressure control. And for controlling BP, we are giving short-acting beta blocker like esmolol, or we are giving nicardipine. So short-acting beta blocker, esmolol, or we are giving nicardipine for blood pressure control. So initial management is controlling the blood pressure. Next, what are the surgical options? Now see, Stanford type A. We discussed that in Stanford type A, type 1 and type 2, these are included. Here, mainly we go for surgical treatment. So we go for thoracotomy and graft repair, or we can go for EVAR, endovascular repair. So here, main treatment is thoracotomy. So we go for thoracotomy plus graft repair. Or we can go for EVAR, endovascular repair, or we can go for EVAR. Clear? But if patient is having Stanford type B, which is type 3 DeBakey, in these cases, what is the preferred management, guys? You have to remember, the preferred management is medical management. So Stanford type B or in type 3 is the medical management with antihypertensive drug. So in which cases we go for endovascular stent placement? Imagine there is increasing pain, or if pain fails to resolve, or patient is having evidence of malperfusion. In all these cases, we are going for what? Endovascular stent placement. Here we go for endovascular stent placement. Endovascular stent placement. Stent placement. So endovascular stent placement surgery, it is reserved for rare cases. So it is reserved. Surgery is reserved for rare cases. Reserved for rare cases who are not responding to any kind of treatment. Clear? So just remember one thing, that for Stanford type A, we are mainly going for surgical repair, that is thoracotomy plus graft repair or EVAR. Type B, these patients are mainly managed medically with antihypertensive drugs. So here you can see how emergency Dacron graft repair can be done. You can see you are going to open the dissection. After that, you are using this Dacron, and after performing the vascular anastomosis, you are going to close it. So this is how emergency Dacron graft repair is done. Now in this image, you can see that there is aortic rupture. And what is the cause? It's because of trauma. So you can see that this is traumatic aortic rupture. And what is the most common site? You can see this is ligamentum arteriosum. So what is the most common site? It is adjacent to ligamentum arteriosum. So first question, the most common site of traumatic aortic rupture, it is adjacent to ligamentum arteriosum. You can see in this image, adjacent to ligamentum arteriosum. Adjacent to ligamentum arteriosum. You can't believe how much is the mortality. The mortality associated with traumatic aortic rupture, yes, it is 75 to 90%. 75 to 90%. So there are certain patients, yes, who are going to die on spot after road traffic accident, or whenever there is fall from height, it leads to sudden death. So sudden death after road traffic accident or sudden death after fall from height, usually it is because of traumatic aortic rupture. So it leads to sudden death in patients of road traffic accident or if there is fall from height. Some patients are brought alive. What is the percentage? Approximately 15 to 20%. These patients are brought alive in the hospital. Here, the most common site of rupture is different. Here, the most common site is aortic isthmus followed by ascending aorta. So most common site in the patients who are brought alive to the hospital, it is aortic isthmus. So that is aortic isthmus, clear, followed by ascending aorta. So this is aortic isthmus followed by ascending aorta. Ascending aorta. Now you can see the tear, how we are going to manage. So you can bypass this tear by the stenting, or you can use the graft. You can go for graft repair. So either you can bypass the tear with the help of stenting, or you can use the graft. Before that, we have to confirm the diagnosis. What is the finding on chest X-ray? Obviously, you are going to find widened mediastinum. So on chest X-ray, there is widened mediastinum. Widened mediastinum. You know that there is rupture of aorta. So can you tell me what is the investigation, which is gold standard? So gold standard investigation for traumatic aortic rupture, it is aortic rupture. So obviously we are going for aortography. What is the investigation? Which is gold standard. This is aortography. And CT or transesophageal echocardiography, this is also useful in diagnosis. So these investigations are also useful in diagnosis. We already discussed how to manage. We have to bypass the site of tear by endovascular intra-aortic stenting, or second option we discussed, we can go for Dacron graft repair. Nowadays, lots of questions are asked related to maneuvers for retroperitoneal exposure. First, Cocker's maneuver. You know that in Whipple's procedure, we perform Cockerization or Cocker's maneuver. Second is extended Cocker's maneuver. What is the other name? This was asked in one of the latest exam. Extended Cocker's maneuver. This is also known as right-sided medial visceral rotation. This is known as right-sided medial visceral rotation. And second is Mattox maneuver. It is just opposite here. What is the other name? It is left-sided medial visceral rotation. And the fourth is Kettlebranch maneuver. It is done for extensive retroperitoneal exposure. This is done for extensive retroperitoneal exposure, right? One by one we are going to discuss. First, see Cocker's maneuver. You know that in Whipple's procedure we perform Cockerization or Cocker's maneuver. So in this case, what is done, in this image you can notice that here we perform mobilization or medial rotation of duodenum. You can see here. So we perform mobilization or medial rotation of duodenum. You can see. After mobilization or medial rotation of duodenum, you can notice that here, this is the duodenum. This is mobilized medially. So after that, there is adequate exposure to head of pancreas. You can notice here. This is head of pancreas, second part of duodenum, and what? The structures which are located posterior to pancreas and duodenum. So there is adequate visualization of head of pancreas, second part of duodenum, you can notice, second part of duodenum, and the structures located posterior to head of pancreas and second part of duodenum, right? What is the use? We discussed that it is used for Whipple's procedure. So this is Cocker's maneuver, also known as Cockerization, in which we perform mobilization or medial rotation of duodenum. Next is extended Cocker's maneuver. So we discussed that this is right-sided medial visceral rotation. So here, the right-sided viscera, it is rotated medially. So right-sided viscera, you can notice what? Right colon as well as duodenum. In this image, you can notice that this right colon, you can see here, right colon and duodenum. This is rotated medially. So name right-sided medial visceral rotation. right-sided viscera, it is rotated medially. So there is mobilization or medial rotation of duodenum and right colon. And after that, you can see there is adequate exposure of inferior vena cava. You can see here. Adequate exposure of inferior vena cava. You can see adequate exposure of infrarenal aorta. You can see right renal artery and what? Iliac vessels. So there is adequate exposure of inferior vena cava, infrarenal aorta, right renal artery and iliac vessels. Now what is the role? Extended Cocker's maneuver, it is used for drainage of inframesocolic hematoma. Can you see? This is transverse colon and here there is transverse mesocolon. Hematoma which is located in this region, that is inframesocolic. So it is used for drainage of, remember, inframesocolic hematoma. Extended Cocker's maneuver, also known as right-sided medial visceral rotation. Now just opposite of extended Cocker's, that is Mattox maneuver. This is left-sided medial visceral rotation. So in this case, you can notice that we are going to rotate what? You can see the left kidney, you can see the left colon. Not only that, you can see the pancreas and spleen. So left kidney, left colon, pancreas and spleen, these are rotated medially and you can see these are brought close to the midline. So that's why what's the name? Left-sided viscera, it is rotated medially. That's why it is left-sided. It is known as left-sided medial visceral rotation. So there is medial rotation of, you can see the left kidney, you can see the left colon, pancreas and spleen. So left kidney, left colon, pancreas and spleen. And it is going to expose, can you see, entire length of abdominal aorta. It is going to expose, you can see the proximal part of here. There is superior mesenteric artery, here inferior mesenteric artery, and you can notice what is this artery? This is left renal artery. So the structures exposed is the entire length of abdominal aorta and the proximal part of superior and inferior mesenteric artery and left renal artery. Now can you tell me what is the role of this Mattox maneuver? Actually it is used for drainage of central supramesocolic hematoma. Clear here? So it is central supramesocolic hematoma. So this is used for drainage of central supramesocolic hematoma, Mattox, also known as left-sided medial visceral rotation. Next is Kettle-Brach maneuver. We discussed that for extensive retroperitoneal exposure, we go for Kettle-Brach maneuver. And in this case, you can see that we are going to mobilize. You can notice that here we are going to mobilize the duodenum, right colon, head of pancreas. So duodenum, you can see here, duodenum, right colon and head of pancreas. This is mobilized and rotated medially for extensive retroperitoneal exposure. So there is medial rotation of right colon, duodenum and head of pancreas. And after that, it is going to expose, can you see, inferior vena cava, almost whole length. So it exposes almost complete length of IVC. Complete length. So you can see here, it is going to expose the complete length of, you can see, IVC. It is going to expose, you can see, right renal vein and what? Iliac vessels. So it is going to expose inferior vena cava almost whole length, right renal vein and iliac vessels, and infrapancreatic segment. Infrapancreatic segment means the area located below the pancreas. So infrapancreatic segment, and we discussed that this Kettle-Brach maneuver, it is done for extensive retroperitoneal exposure. Now we are going to discuss vascular graft because it's very, very important. First, tell me what are the types. It can be bioprosthetic, it can be synthetic. Now see the types of bioprosthetic vascular graft. Autograft. Auto means self. So patient's own tissues are used. So when patient's own tissues are used. So if patient's own vessels are used, this is autograft. Allograft. Allograft. Allo, this is also known as what? Homograft. Allograft, also known as homograft. Here, when the graft is taken from same species. So graft is taken from same species, same species, same species. Clear? If you know Punjabi, it is easy for you to remember it for long. Suppose there is a mother and mother gives her kidney to the son. Or mother kya bolti son ko? Allograft. Then it becomes allograft. You got it? So what is allograft? This is homograft. When the graft is taken from same species. Xenograft, what is the other name? Also known as heterograft. So xenograft, that is also known as heterograft, and it is taken from different species. So when it is taken from different species, that is xeno or heterograft, and whenever it is prepared in laboratory, this is tissue engineered. So these are bioprosthetic, after that synthetic. First is textile graft. Can you give me the example? Yes, Dacron. And you know that Dacron, this is the most commonly used synthetic graft. Dacron, that's the most commonly used synthetic graft. After that, non-textile graft, first is ePTFE. Guys, tell me the full form. What is the full form of ePTFE? E means expanded polytetrafluoroethylene. So this is expanded. Full form, it is expanded polytetrafluoroethylene. Okay? Expanded polytetrafluoroethylene. So it is expanded polytetrafluoroethylene. Ethylene, this is one. And the second is polyurethane. So this is polyurethane. All these are asked in exam. Polyurethane. Polyurethane. So most commonly used, it is Dacron. Synthetic graft, it is Dacron, right? So now we are going to discuss the important questions related to graft. First, what is the best natural vascular graft? You know, the longest vein in the body is long saphenous vein. You reverse it because inside there is, inside the vein, there are valves. So we reverse it. So outside lumen goes in, inside lumen goes out. So best natural vascular graft, it is reversed long saphenous vein. You know that. What is the other name of long saphenous vein? It is also known as great saphenous vein. And what is the best synthetic graft? We discussed. This is Dacron. Next, preferred vascular graft for suprainguinal bypass and infrainguinal bypass. If you go in infrainguinal region, there is medium-sized and small-sized vessels. For that, we use long saphenous vein. But in suprainguinal region, there is aorta, there is iliac vessels. So for that, we are using Dacron. So for infrainguinal bypass, we are using long saphenous vein. Suprainguinal bypass, we are using, yes, Dacron. We are using Dacron. Another topic which is very important, asked frequently, CABG, coronary artery bypass grafting. Can you tell me what is the most preferred graft? First tell me. Arterial grafts are preferred or venous graft for CABG? Arterial. Why? Because arterial graft, the lumen is non-collapsible. Patency rate is longer, right? Higher, right? But what venous graft? It is going to open during systole, going to collapse during diastole. So what is the problem? Venous graft are having lesser patency rate. Arterial grafts are having longer patency rate. That's why arterial grafts are preferred. So most preferred vascular graft for CABG, it is Lima. What is this? Lima. That is left internal mammary artery. In this case, you can notice that here there is stenosis and we are using this Lima. So this is the bypass graft, left internal mammary artery. What do you mean by bypass? Suppose this is the site of stenosis. You are going to bypass the stenosis and what? The blood flow to the distal area is established by the bypass. Clear? So most preferred vascular graft, that is Lima. But what is the problem? Usually when the patient is having triple vessel disease or double vessel disease, you have to use another graft because we have only one Lima. So most commonly used vascular graft is long saphenous vein. Why? Because it's very long. So we can go for 2-3 bypasses with long saphenous vein. Nowadays we can use radial artery also for CABG. So most preferred Lima, most commonly used long saphenous vein. Another graft which can be used, that is radial artery. Now see this diagram is very easy. This is aorta. You can see here aorta. This is internal iliac. Internal iliac. This is external iliac. After that it is femoral. Femoral artery. Now imagine the patient is having bilateral iliac artery obstruction here. There is obstruction here. Bilateral iliac artery obstruction. So in this case, what kind of graft is used? You can see here. I'm using a graft like this. Can you tell me? So from aorta, I'm going to attach the graft to the femoral. So what is the name? This is aortofemoral bypass. So for bilateral iliac artery obstruction, we are going for, can you see? This is aorta. So aortofemoral bypass. And you know what is the preferred graft? Dacron. So the preferred graft is Dacron. So remember, for aortic bypass, for aortic reconstruction, for suprainguinal bypass, preferred graft, it is Dacron. So guys, let's discuss the MCQs. First question, which is very, very important. Abdominal aortic aneurysm is operated when the size is greater than, so it's more than equal to 5.5 centimeter. Abdominal aortic aneurysm, obviously what's the correct answer? C. It is C. For descending thoracic aorta is more than equal to 6.5 centimeter. Next question, most commonly involved artery in pseudoaneurysm formation. What is the cause of pseudoaneurysm? Whenever you are going to puncture the vessel, what will happen? After that, what happens? Blood is extravasated and only 2 layers are involved, not all the 3 layers. So the artery which is most commonly used by cardiologists, radiologists, and even interns for puncturing, what's that? Femoral. So most commonly involved artery in mycotic aneurysm as well as in pseudoaneurysm, it is femoral. So what is the correct answer? It is femoral. This is femoral. Next question you can see, what is the appropriate management for a patient presenting with constant chest pain and radiological findings suggestive of Stanford A, aortic dissection? We discussed if it is Stanford A, so mainly we are going for thoracotomy and graft repair. So for type A is the surgical management, but for type B, in which type 3 is included, for type B, mainly it's the medical management with antihypertensive drug. So for type A is the surgical management, we go for thoracotomy. What we do? Thoracotomy plus graft repair. So it's the thoracotomy plus graft repair. And for Stanford B, it is mainly antihypertensive. So Stanford B, medical management, is the medical management with antihypertensives. Antihypertensive. And for BP control, you know that in aortic dissection, which agents are used? We are using short-acting beta blocker, that is esmolol or nicardipine. Clear? So correct answer for this question is A, and this is all about arterial disorders part